Ashley, and welcome everyone. I see a lot of guests this evening. I will get back to them towards the end. I'm excited. I've been excited every week for this month, every forum, because we've had some wonderful guests. And I just want to take time, as I usually do, to introduce our guest for today, Dr. Al Reece, from the University of Maryland. I'll go into details about that. And he's here to speak to us today on the interface of medical care and politics, Christ following advocacy. Dr. Albert Reece is the Executive Vice President for Medical Affairs at the University of Maryland, Baltimore, the John Z. and Akiko K. Bowers Distinguished Professor and Dean of the School of Medicine. He's also professor in the departments of obstetrics and gynecology, medicine and biochemistry, and molecular biology. He's a member of the prestigious National Academy of Medicine. Originally from Jamaica, West Indies, Dr. Reece completed a Bachelor of Science degree with honors, magna cum laude, from Long Island University, an MD degree from New York University School of Medicine, a PhD degree in biochemistry from the University of the West Indies, Kingston, Jamaica, and an MBA degree from the Fox School of Business and Management of Temple University. He completed an internship and residency in obstetrics and gynecology at Columbia University Medical Center and a postdoctoral fellowship in maternal fetal medicine at Yale University School of Medicine. He remained on the full-time faculty at Yale for almost 10 years, during which he served as clinical instructor from 82 to 84, assistant professor from 84 to 87, and received accelerated promotion to associate professor in 1987. In November of 1990, at the age of 39, he was recruited by Temple University to serve as the Abram Roth Professor and Chairman of the Department of Obstetrics, Gynecology, and Reproductive Sciences. Between 2001 and 2006, he served as Vice Chancellor of the University of Arkansas for Medical Sciences and Dean of the College of Medicine. And in 2006, he was recruited by the University of Maryland to serve in his current capacity as Dean. In 2010, Dr. Reece served as acting president of the University of Maryland. In addition to his administrative responsibilities, he's actively involved in research and education. Now, his research focuses on diabetes in pregnancy, birth defects, and prenatal diagnosis. He directs an NIH multi-million-dollar research laboratory group studying the biomolecular mechanisms of diabetes-induced birth defects. His laboratory has determined that there are specific cytoarchitectural changes of the epithelial level of the cell associated with these anomalies. Biochemical changes include depletion in membrane lipids and phospholipids, as well as excess free radicals. His group is now studying the molecular mechanisms and methods to prevent these anomalies. He and his colleagues have also developed the technique of embryo fetoscopy for early prenatal diagnosis and eventually for curative fetal therapy. He's a sought-after visiting professor and lecturer at numerous institutions, both nationally and internationally. He has published extensively in the scientific literature, 12 books, including revisions, 5 monographs, and more than 100 articles, chapters, and abstracts. He recently served as chair of the Council of Deans of the Association of American Medical Colleges. He serves or has served on many governmental and civic organizations and committees, such as the FDA, the IOM, and the NIH, the Secretary of Health and Human Services Committee on Infant Mortality, the March of Dimes Birth Defects Foundation, the Massachusetts General Hospital Scientific Advisory Committee, the board and chairman of the Nellie Berman Classical Music Institute and the Agnes Irwin School for Girls. He receives numerous special recognitions and awards, including the Distinguished Leadership Award in 2009 and the 2010 Burson Medical Alumni Achievement Award in Health Sciences from his alma mater, New York University School of Medicine, and the 2010 Distinguished Service Award from Loma Linda University. Dean Reece is married to Sharon Reece, M.A.J.D. LLM, a visiting associate professor of law at the University of Maryland School of Law, and they have 3 daughters, Kelly, PhD, Bryn, DDS, and Sharon Andrea. I've known Dr. Reece for upwards of 55 years. His wife, Sharon, was a bridesmaid in our wedding. He's my childhood friend. And of course, he grew up with my wife. They grew up together in Spanish Town. And when I grow up, I want to be like him. I want to welcome him, welcome his relatives here, his sisters here. Dr. Linville is here, who is a brother-in-law, and others. I'm excited to present him to you. I welcome all other guests who have joined us today in the field of medicine, et al. And I hope you understood all that I said, because I said it very, very clearly so you could understand who this gentleman is. And then he will explain for himself who he is with respect to his knowledge in medical care as it interfaces with politics and how we can advocate as Christ followers. Dr. Al Reece, you're on. People unmute him, please. He needs to be unmuted. Yes.
Can you hear me now?
Yes, yes, indeed.
Dr. Hoylett, thank you very much for inviting me, and thank you for that generous introduction. It's more than I was expecting, but thank you for your kindness.
You're welcome.
I'm looking forward to being with the youth of your church and many guests as well. It's a pleasure to be here and to speak on this very important topic. I'm going to try to see if I can share my screen, and you have to bear with me. My technological skills may be very mature, so here I go and try now. Okay, can you see my slides?
Yes.
Okay, let me see if I can even increase the size of it.
If you click slideshow at the top.
Yes, I
and
did.
Then click from the beginning.
I've clicked the slideshow.
Yes.
And, oh yeah, okay. Yes, okay. That should do it. Okay, wonderful. Is that now much larger? Perfect. So as Dr. Hoylett said, I'm going to talk to you a little bit about healthcare, COVID-19, and what I call social implications. I just sort of shortened it, but in essence, it is what Dr. Hoylett described. A very important topic. But let me just point out here that healthcare in America is heavily based on health insurance. Now, in Western Europe, for example, whether it be France or Germany, healthcare is really part of the state's or the country's provision that comes with just being a citizen. So healthcare is automatic, it's free, as opposed to in the United States. Healthcare has to be purchased through health insurance. So it's important for us to first understand health insurance because it's so very fundamental to healthcare. So let me start with an overview on health insurance. So let me go to the next slide. And when we talk about the importance of health coverage, it is very much involved in in the enrollment of healthcare. And there are 4 elements that in healthcare provides. One is access to care. And that whether it's prescription drugs or diagnostic studies for cancer or heart disease, or timely and less complicated treatment. So that is kind of the first, is access to care. Second is positive health outcomes. And that is someone who is enrolled in a healthcare program typically has better outcome than someone who is not. Whether it happens to be, even if disease is identified, disease often is identified earlier, treatment and intervention is earlier, so outcomes typically will be better. Is the appropriate use of healthcare resources. For example, if you're involved in a healthcare coverage, you typically will access physician service much more frequently. And I'm going to give you a story, a personal story later on, but I want you to file what I'm saying now, and that is appropriate use of health resources if you are enrolled in a healthcare program. File that away, you'll find it useful when I give my story. Also, there'll be greater use of preventive health measures, preventive measures against diabetes or hypertension or stroke or epilepsy. All of these will be used. And lastly, reducing financial strain on the family, on the individual, on the society. Here's another important one that I want you to also file away. So you're going to see that I'm giving you lots of stuff to file away. This one here is, in America, without health insurance, which essentially means health care, there is absolute established data that there's increased death, increased illnesses. That to me is bedrock, is fundamental what I'm going to say. Insurance results in health care, and health care results in better outcomes. And the converse is true. The absence of health insurance results in a decrease in health care, an increase in death and morbidity. File that one away. Now, when we talk about, for example, health insurance, there are basically 3 types of health insurance, or 3 categories, let's say categories. One is public health insurance. Second is private health insurance. And I want to say the third category is no insurance. Now, if you look at on the slide, you'll see that there is in Washington called CMS, the Center for Medicare and Medicaid Services, CMS. And CMS is really the entity, the governmental entity that encompasses Medicare, for which 62.5 million people are enrolled, mostly people above 65. There's the Medicaid, and that's often for people who are disabled, whether it be adults or children, and usually people below a certain age, below a certain income level, sorry. So that's Medicaid, but that's the public health insurance, the public health insurance. Now there's private health insurance that you can purchase, like Blue Cross Blue Shield or United or Cigna. Those are private health insurances. But you'll see that 68% of people in 2019 had private insurance. 55% had employer-based. Here's another point to keep in mind. In the United States, health insurance is often, not always, but often linked with jobs. So you're having a job, you automatically get health insurance with it, for the most part. There are certain jobs that really come without benefits. But those jobs that do come with benefits have insurance, have health insurance in it. So very often you'll see that 55% of people have what's called employer-provided health insurance coverage. 9%, as much as 10% of people are uninsured. And that's almost close to 30 million people. So it's not a small number. But look who they are. 5% are white, 5% are Asians, almost 10% are Black, almost 17% are Hispanic. These are uninsured people, close to 30 million. I want to keep those numbers. About 30 million are uninsured, and their breakdown, if you look at just the minority population, you're talking about almost 30% are minority population, okay? Now you look at the expenditures. The cost of care, very much so, very high. In the industrialized countries worldwide, America pays highest expends the greatest amount of dollars for healthcare. If you think of our gross domestic product, and that is simply considered to be or total economy, or total fiscal economy, we spend almost 20% of our economy on healthcare. That may be the good news. That we're the worst in terms of industrialized countries relative to outcomes that could be to morbidity, to mortality, and to longevity. So we spend the most, again, within the industrialized world, not totally, but we don't have the best outcomes. So how much is it that we spend? You'll see that we're spending almost 20%. In this study I have here is 18% of our gross domestic product, which is about $11,000, $12,000 per person. So again, keep it in mind. I want to keep the big concept. There are 330 million people in the United States, and the government is paying almost $12,000 per person. Is expending that much on an individual, but the outcome is not necessarily the best in the world. So what's the impact of that? Almost $3 trillion in health insurance expenditure is made in this country. Almost half and half private versus public. About more than $1.2 trillion for private insurance, and roughly speaking, $1.3 million for public insurance. So it's 1.3, roughly speaking. So you can see it's a pretty high amount of expense with some overlap. There's also another bucket called the Children's Health Insurance Program, or CHIP, close to $20 billion. And the rest is military or folks like Department of Defense or Veteran Administration. You can see 78 billion versus 42 billion. So you get a feeling for the way that the cost of care. So I just want to stop here and just emphasize a point. We are spending a huge amount of money on healthcare. Yet at the same time, our outcomes is not the very best. In addition, that is on people who people who are covered. We said to you earlier that close to 10% are not covered, meaning are uninsured. And that's about 30 million people are uninsured. And I said earlier that if you're uninsured, you typically do not have very little care. And I also said it's a higher rate of morbidity and mortality. So that's pretty serious. The question is, what are we going to do about that? So let's move on. Well, in 2010, President Obama became president, and he was impressed by those numbers, like you should be, and we are all impressed by these numbers. When you look at this for a moment, look down at this level. Let's see if I can use my pointer. Where's my pointer? Well, you'll see where it says on the number 1, before the Affordable Care Act that we call Obamacare, there are more than 44 million people who are uninsured at the time. That's a lot of people to be uninsured. And these people who are uninsured typically have a shorter life expectancy and have greater morbidity and mortality. So President Obama worked hard and introduced, the first time ever in history, an attempt to have what's called a Care Act. So more people would have insurance and thereby have a better life. The 3 goals of that insurance provision was as follows. 1, to make health insurance more available and more affordable. Like I said, health insurance is not a right in this country. Healthcare is not a right. It's something you have to purchase. So he wanted it to be much more available, much more affordable. And I said before, he started out with more than 44 million people uninsured. By the time he introduced it, it was cut in half, 20, 22 million people. Now it has crept up to 28 million people. And you may say, wait a minute, what happened? He cut it down to 22 million. And now it's almost at 30 million again. Not again, but 30 million, it's edging up there. I want you to file that as a question, and I'm going to give you the answer in a moment. But you should at least noticed that there's a creep going back up. Well, the second objective of the Affordable Care Act, the ACA, was to expand Medicaid. I said Medicaid was for lower income persons, citizens, and also for disabled children or adults, or sometimes even adults in nursing homes whose insurance has run out. They can go on Medicaid. So it's really for individuals who are distressed economically or distressed physically with disability. So the idea was to expand Medicaid to cover adults with incomes that was way below the poverty level. All right? Many states have done that over time. It's a 10-year period. But there are 14 states that still have not expanded Medicaid. And that was a pretty easy thing to do because the provision of that act, the Affordable Care Act, was to allow for Medicaid expansion and automatically cover more patients by so doing. The third goal of that act was to support innovative medical care and methods so that there could be lower cost. Well, much was accomplished by the ACA, but there are some other things, very important I want to emphasize. Let me just move this up a little bit. The next is that the Affordable Care Act introduced 10 essential health benefits. And what I mean by that, let me explain that to you. You can purchase anything and have that thing, whether it be a car, a bicycle, an instrument, but it may not be worth a whole lot. So insurance, you could buy an insurance policy, but it doesn't cover a lot of things. The Affordable Care Act required that 10 essential elements must be part of all insurance plans that you buy. 1, all outpatient care must be covered. Just imagine some wouldn't even cover outpatient care. 2, all emergency service must be covered. 3, hospitalizations must be covered. How could it not cover hospitalization? Pregnancy, maternity, newborn must be covered. And here's the 5th one that really was almost always not covered. Mental health and substance abuse must be covered. Number 6, not always covered. Prescription must be covered. Rehab services must be covered. Not always covered. Lab services. Number 9 is another biggie. It was almost never covered. I recall going to the Senate once in my state of Maryland. And the senators asked me, Doctor, why aren't you providing preventive care for, not me, but why doctors aren't providing preventive care for patients? You know that prevention is better than cure. And I said, Senator, the reason is in part because it's not reimbursed. So there's no incentives for doctors to do it. We do it out of the goodness of our hearts, but it's not done in an extensive way. It's done, just a very slipshod way. A doctor may give it in passing, but there isn't a preventive wellness program. Now, President Obama required that it had to be included in every plan that was sold in America. And last, pediatric services. Dental and vision were rarely covered. The Obamacare required that to be covered. So those are 10 essential healthcare benefits that were really a huge advantage. There's some other benefits, and look at this one as well. Pre-existing conditions. If you had diabetes, you had heart disease, you could have had a heart attack, 3 heart attacks. In some plans, they would not cover that. Or a setup for problems. So they didn't want to cover you. They want to have people who had low risk, so the payments that they would make would be low payments and not focus on the health and well-being of the individual. So pre-existing condition was a very, very big deal. That was a major advance in being a part of all plans. Number two, it made it illegal for the health insurance company to cancel coverage if a patient got sick. I mean, you got sick, that's the time you want to use an insurance. Where some insurance companies were what they call disincentivized. They had a disincentive to continue your care. Third, women cannot be charged more than men for health insurance. So like a no-brainer, but that was put in there as another benefit. Free preventive care, I mentioned that earlier. Children up to age 26 could remain on their parents' insurance. That was huge. So throughout college, you could still be on your parents' insurance as opposed to what it was before that. And also they had to end yearly limits on coverage, and breastfeeding equipment and support, mental health and substance abuse must be in there. So these are important bedrock elements of the ACA that I think that sometimes people don't even appreciate how far we have come. And I'm speaking now in addition, but I can tell you that the American Medical Association, the American Academy is all behind it. This is what I would call a no-brainer for health professionals. They see something that is very, very fundamental. You know, so the question is, what has happened since? It's been 10 years the Affordable Care Act was introduced. Well, a number of things have happened, and I will just say the following. Since that time until now, there have been a number of debates. You have probably heard them as well as I have. Debates in the public, debates in the press, and there are crossfires as to efforts to undermine that act. So here are some changes, 4 major changes that have been successful in eroding the Affordable Care Act. Number 1, the individual mandate. And what's an individual mandate? If you think of an insurance company, if you had to start an insurance company, well, premiums are being paid by individuals, but you want the more money to be paid in than is paid out. So what insurance companies would do, they would have people with as low as risk as possible. So they're paying out less. Well, in fact, if you're going to insure more individuals, you want to have as many people in the pool as possible. People who are low risk, and of course, some people with high risk. And so the requirement of the Affordable Care Act really was to get as a huge pool of individuals in the mix. And in order to ensure that happened, the ACA required, or basically, if you did not have insurance, there was a penalty for not getting insurance. It required there to be a financial penalty for not having insurance. It really was almost like you have a driver's insurance. You can't drive the car unless you have insurance. You can't, you got to have IRS, you got to do your tax return. So that was important. And you can imagine there are some parts of the nation that don't believe that that individuals should be directed to do one thing or another. They want to have some freedom of choice. Well, it's been successful in eroding so there has been an elimination of that mandate of everyone having insurance and being penalized if they don't. Number 2, states have been permitted to really add a work requirement to Medicaid expansion. In the original act allowed Medicaid to be expanded in a state just based on an application. Whereas now some states allow for that to occur providing there's a work requirement added to the eligibility. The third is a termination of cost sharing between federal government and the insurers. And the cost sharing was important because the cost sharing allowed the cost to be lower for the individual citizen. Well, that has been eliminated. A fourth is because the AC has been injured somewhat, those requirements, those 10 health benefits and the 10 health essential that must be in every insurance sold has been watered down. The minimum coverage allowed has been reduced. So that is what has happened, major changes, but it still exists. It's still worthwhile. It's still being quite useful, and many people are still using it. So as you know, there's a good possibility that the ACA could be repealed. As we speak today, the ACA has been is now in the Supreme Court being argued. In fact, I think it's going to be the 10th of this month. It'll be argued that it should be dismantled altogether. And the proposal that is being made legally, and I'm not a lawyer, but I'm going to tell you as much as I know, is that a group of attorneys general has proposed that since the first bullet, there has been elimination of the individual mandate. Essentially, it has weakened the law, and they think that the whole law should be thrown out because its main underpinning has been injured. So why have a shaky, fragile law continue? So that is, there's a much obviously stronger legal argument. I can't go into the legalese, but suffice to say that is under discussion right now. It is also believed that there is the vote in the Supreme Court for that to occur. That's the likelihood. So the question you may ask is, what would happen if it's repealed? Well, you can it's sort of the opposite of what I just said earlier. One, people would lose that pre-existing condition requirement, which is a big deal. That you get coverage, you can buy an insurance if you were sick. If you, God forbid, you had diabetes and you had stroke or you had a heart disease or you had this, you couldn't, in the old days, you couldn't buy insurance because you couldn't afford it. Under the Affordable Care Act, that should not preclude you from having a good insurance. In this case, if it was repealed, your pre-existing coverage would be removed. More than 20 million people would be uncovered. Small businesses and self-employed entities would also increase. Communities of color, in particular, would be impacted. Young people under age 26 would have to start paying their own insurance, or going without insurance. Insurance for women may necessarily go higher than men as it was in the past. Uninsured families would risk having their children to support. Drug costs for seniors would increase. So those are some of the realities. These are not speculation. This is just facts. These are the things that are currently covered, and these are the things that are at risk. So now the question is COVID. If it weren't for COVID, I would be visiting Dr. Oilet in person and seeing your faces and get a chance to having a nice time with you. But COVID is here, and we are trying to make the best of it. Thank God for Zoom. We're able to at least able to interact. So COVID has an impact on health insurance. Don't forget, health insurance is the bottom line. If you don't have any health insurance, you're likely not going to get good health coverage. And if you likely don't get good health coverage, you may either die or get sick. As simple as that. 21 people were unemployed in May of this year. More than 13% of the labor force this year because of COVID. Nearly 30 million people could lose their employer-sponsored insurance because of COVID-related job loss. A third of all small businesses may go out of business. And COVID is now considered to be a pre-existing condition if you've had it. So just from COVID alone, if the Affordable Care Act was repealed, more than 8 million people, more likely 10 million people, may no longer be eligible to purchase insurance if the ACA is not, they can purchase insurance like anybody else. So my point is, these are some of the things that are at risk, given the political climate in which we live, and given the circumstances in which we exist. So I would say our health is actually on the line. So that was an introduction to the COVID and our community health. So let's transition to COVID. What is COVID? So COVID, as you know, is corona virus disease that began in 2019, COVID-19. And COVID-19 is a disease. It's not a virus. So sometimes people say, I got hit by the COVID virus. Well, not quite. COVID is a disease caused by a virus. So it's a respiratory disease caused by a new, and you sometimes hear the word novel coronavirus. It's called SARS-CoV-2. That's the name of it. SARS is severe, A, acute, R, respiratory syndrome. So severe, acute respiratory syndrome. COVID virus number 2. So you obviously figure there must have been a number 1. And several years ago, there was a number 1. And so this is SARS-CoV-2. COVID-2 is really the coronavirus. So coronavirus is really is a family. It's a family of viruses. They're mostly in animals. And they rarely spread from animals to humans, and even not so much from person to person. That's rare. There are a few exceptions in the world so far. There are 3 outbreaks from these families. One is SARS-CoV-1, let's call it. It's called SARS-CoV. And MERS, it's Middle Eastern respiratory syndrome. And that happened in the Middle East maybe, I'm off now, maybe within 10 years, maybe 7, 8 years ago. And now we're having the SARS-CoV-2. So it's each of these viruses are slightly different, but they're within the family of, it's called coronavirus. And the reason why it's corona, I'm not sure if you're seeing on my slide a kind of a round ball. You can see that little ball? Yeah, okay. And you see little spikes on them. So that's why it's called corona, because these are proteins. Those red things are protein, and they're attached on the viral envelope. So the virus has an envelope, and all those little red things are protein spikes. Sometimes you hear people call it spike proteins. So you really want to develop antibodies against those spike proteins to kill that virus. That's the goal of the vaccine. So the vaccines are always made using those spike proteins as antigens. So the COVID-19, or the COVID-19, which is a coronavirus disease, is believed to have originated in bats. And initially, person-to-person spread was limited to those who had direct contact in the Hubei province in China. Unfortunately, in this year, 2020, in February, was the first reported case in the United States where there was not any known contact or travel. There are a few cases before February 1st, but they were known travelers bringing it in from outside. So you kind of discount those because you knew that where they came from. The first case of so-called community spread was February 26th. And then we know we were in trouble. So where are we today? October 21st, when I put these slides together. We're in a pandemic, obviously. So far, you can see 189 countries are involved, have disease. This is something serious. And this has not happened in the last 100 years. The last one was, again, 1918. And you'll see over 41 million confirmed cases worldwide. Over 8 million confirmed cases in the US. We have the highest in the world. And keep in mind size. China has about, you'll see 1.5, 1.6 billion people. India has about 1.2, 1.3 billion people. What do we have? We have 330 million people. I'll never forget the time I was in China and walked into the hotel room. It was like a basketball court field. I'm thinking, oh my gosh, this is incredible. You're driving the road and you know, it was so huge. And I had to reflect and realize, you know, China is 5 times larger than America. And then it sunk into my head, no wonder the place is so huge. I mean, the roads are tremendous, and the buildings, they're building just sort of for regular home buildings for houses, and they're building 20 at a time. We build one at a time. They're doing 20, and they're building it around the clock. So my point is, we have the highest number in the world, despite the fact that we're 5 times smaller than China. There are 137 confirmed cases in my state, Maryland. And worldwide, over 1 million deaths, 1.1 million deaths. And you'll see that in the United States, 220 plus, highest in the world. Highest in the world in cases, highest in the world in deaths. And this is, to put a Florida spin to this, it's bigger than the population in Tallahassee. It's like the whole of Tallahassee was wiped out, God forbid. And the number of deaths in Florida, your state, is the 4th highest in the United States. So that is just to give some context. So I wanted to look both on some of the words on this slide and look at the cartoons. The cartoons, I think, will help you remember this better. So what are the symptoms of COVID-19 disease? It's like it ranges from mild to severe. But think of it as a very bad flu, a deadly flu. You'll see, if you just look at the cartoons, you'll see cough, shortness of breath, difficulty breathing. See the man has his hand over his heart, difficulty breathing. You'll see there's a fever, temperature, the thermometer there, muscle and body aches, nausea and vomiting. You'll see that there's, and a very important one is loss of taste and smell. I'll tell you a quick story. At my hospital, we began, maybe back in March or so, I forgot now, started to take people's temperature at the door before they came in. And over the next several weeks, we realized that it was not very sensitive. That was reportedly the most sensitive test, was take a temperature. No, we found that people reported loss of taste and smell sooner than their temperature going up. So we had to abandon the temperature, start doing a mini survey at the door. And people will say, you know, will tell you, those who are coming down, it's funny, I was eating and I completely, it's an odd feeling. I'm not tasting the food anymore. And it's not subtle. So those are clear symptoms. Symptoms may appear 2 to 14 days after exposure. But here's something new to keep in mind. Sometimes people, especially young people, if they get the COVID-19, will recover. Not always. Some will die, unfortunately, but some will recover. And we sometimes, young and old, will think that that's the end of it. In many cases, that is the case. That is true. But in many other cases, they have lingering symptoms for weeks or months. And this is called the post-virus symptoms or syndrome. And so here are these. They're just prolonged fatigue. One couple says their husband was sleeping all the day, couldn't understand. He got better, but he continued to be sleeping in the middle of the day. That was very unusual. Fatigue. Their mind is cloudy. It's sometimes referred to as brain fog or headaches. These are after you've been you have recovered. The shortness of breath or chest pain and cough, chills, lingering loss of taste and smell or hear loss. This is just some of the prodromal, prolonged symptoms. Nowadays, there's a new term I've just learned called long haulers. The long haulers are people who, after a long time after, will still continue to harbor symptoms that sometimes could be quite serious. So it's not a simple disease. This is a deadly disease. So how does it spread? Again, you can look at the words or you can look at the cartoons. The cartoons can be very helpful. But the bottom line, it's a highly contagious disease, more so than flu. It's person to person. And contact, you can see, is within 6 feet. You need to stay away 6 feet or more if you can. Respiratory droplets are very potent. If you see a little video to show that when we talk, there are certain droplets that will be expelled from our mouths that will become airborne, and it'll take a while to fall to the ground. So these are the droplets. It's called aerosol. You'll hear people say aerosol. Now I'm going to give an example of something. In our hospital, we have to, if we're doing surgery on patients, and we intubate the patient, put the tube in, the breathing tube in, we have to wait about 20 minutes before we can start the surgery, because the room has negative pressure. It has suction out air. But the droplets that will come out, we have to kind of try to evacuate the room with all the aerosol that became in the air. So these are real. It's a way of protecting the doctor, the nurses from this aerosol. So we end up having to go slower. It's not a matter of just intubating and start surgery, but you intubate, put the breathing tube in, and wait until the room, the air has been purified. Maybe it's another way of saying it. So as I said here, contact with infected surfaces, not so common. Airborne transmission, very common. That's the key, airborne. That's why masks are so important. Large gathering in closed spaces. Large gathering in closed spaces is a bad idea. Very bad idea. Large gathering is a bad idea, period. But in closed spaces, it is even worse. For the obvious reason. The reason is that you're containing those aerosol droplets. They're not able to be dissipated. People are most contagious when they're most symptomatic. So if you know someone who has COVID-19, obviously you stay away. But they're most contagious when they are symptomatic. You'll see people without symptoms can still be spread coronavirus. It's called asymptomatic carriers, asymptomatic spreaders. They may have it and they may not even realize they do because the symptoms are so mild. They're still contagious. So here, the preventive measures are something that we should remember. There is no vaccine at the present time, and there's no preventive therapeutic measure. I want to emphasize that. There's no vaccine, and there's no current treatment for prevention. No vaccine, no current treatment for prevention. So let me talk what we can do. There are public health measures. Mask wearing is something that is a true and tried health measure. And we all should be wearing masks. And we may have to be wearing it for a long time, even after the vaccine. And we can talk about why after the vaccine. We should be avoiding close contact with people who are sick. We should stay away 6 feet or so away. Avoid touching our own eyes and nose. And the cartoons on the screen will help you remember it. You, again, cough, cover your cough or your sneeze. Clean, disinfect, and frequently touch faces or surfaces, rather. Wash hands often. Wash if you can. Stay at home if you feel sick. And I said before, there's no specific antiviral treatment for COVID-19. I'm going to tell you about something more general, but there's nothing specific. So since there's no treatment and there's no vaccine, we have to really rely on preventive measures. There's no FDA-approved treatment for COVID-19 infection. Now, the one drug called remdesivir, and this drug was studied at my institution as part of the team and recommended for patients who are severe, requiring supplemental oxygen. It's an IV drug, so it's only given in you're hospitalized and you require supplemental oxygen. It was shown in the initial study to lower the time of your illness. Doesn't prevent, and it doesn't cure, and it doesn't treat, but it just the length of your complication has been lowered by about 15%. The drug still remdesivir. By the way, there's a study just recently, within the last 2 weeks, done by the World Health Organization, that found that this drug, remdesivir, is the only FDA-approved drug for COVID, does not reduce death or length of hospitalization. So it is all we have, so to speak, and it is thought to be helpful for patients who are on oxygen, but as the most recent study now showing that it does reduce the death and does reduce length of hospital stay. The drug still has utility for patients who have severe disease. The next drug that is used sometimes is believed to have an additive effect, and the President of the United States used that as well, and that's steroid. Steroid is commonly, it's a regular drug on the market that doctors can prescribe, and you can, any of these are steroids. The President of the United States, he got dexamethasone, but there's prednisone, methylprednisolone, hydrocortisone, all those are all steroids and can be used. There's another more experimental drug called convalescent plasma. Convalescent means recovering. Someone who has had the disease and is recovering, they have antibodies in their plasma. So it calls convalescent, that maybe it has antibodies it's like a vaccine, but it's not. And that is being studied. It's not really proven. And the reason I say this is, let me clarify this. The virus is called a novel virus, which means we don't know a lot about it. Under normal circumstance, if you get a disease, you typically will develop antibodies and make you immunized against getting it again. Except this, you're not sure it gives you full immunity. There are people around the world who have been reinfected after having been infected the first time, which tells you it's not full immunity. So convalescent plasma is a good idea, but we're not sure. It's still experimental because we're not sure of its total effectiveness. So these medications are not recommended. Let me tell you what is not recommended, because they have not been proven at all to have any effect. Chloroquine, hydroxychloroquine, with or without an antibiotic called azathioprine. Lopinar, Ritinar, or other HIV drugs. So those are not recommended. They have been in the news and thought to be helpful, but they're not in any way proven. So with regard to vaccine, we'd love to have a vaccine. Everybody wants a vaccine so we can come back together. But let me tell you, there are 9 vaccine trials candidates right now in the phase of testing called the phase 3 trials. 9 of them worldwide. 3 are in the United States that are the front runners. At my institution, in my medical school, we're studying all 3 of them. The front runner is probably Moderna. The next one just started last week. We enrolled the first patient here last week. It's a Maryland-based company called Novavax. And the third one is Pfizer. So these are the 3 front runners. And we should be praying that all 3 win. This is one time we want all of them to win so that at least we can get some coverage from one or more. There are others, you can see a few in China, one in Russia, one in Australia. There's also one in England, but 2 have been paused so far because of complications. So the bottom line is that there are many vaccine trials underway at the present time. The 3, at least, we believe the 3, we expect at least one of the 3 truly will make it. We don't know, because these are randomized trials. Some patients are getting placebo, some patients are getting the real stuff. We don't know. And then Moderna, for example, we need to do 30,000 in the United States. We should have completed the 30,000 by the end of October. The Novavax has just started. I think it could be about 4,000 people. So all of this is in play, and we're hopeful that it will work. I just want to say a word, and you'll hear in the newspaper, in the news about herd immunity. It's a bad idea. Let me just start with that. It's a bad idea. What is herd immunity? If you look at the diagram, you'll see that in the bottom there, in the bottom left, you'll see a lot of people. All it means is that you want a population to either become immunized by vaccine or immunized by having the disease. If the disease is a lethal disease, and a lot of people are getting the disease to become immunized, you're gonna have a lot of dead people. I mean, it's as simple as that. So in order for America to use herd immunity in the absence of a vaccine, it's going to require us to expose ourselves and get the disease, and a certain percentage will die. If that were to happen, there'll be 230 million cases in America for that to happen, and about 700,000 deaths for that to occur. So that is not wise. It's not smart. It sounds good, but if you have vaccines, it's a different story. If you have 70% of the population that is vaccinated, then the virus will die down, because essentially it doesn't have anywhere to land. Most people it land on are already immunized from the vaccine. That's a different story. But to get the disease itself to become protective of the community, you're going to have a lot of sacrificial people in order to immunize the community. And let me remind you, this is a statement made many years ago. It says, those who cannot remember the past are condemned to repeat it. And in 1918, the Spanish flu, as you can see on the left side, wiped out millions of people. Multi-million people were wiped out. The right side of the screen is where we are today. We're not there yet, but we got to remember that they can claim that it's 100 years ago and maybe the science and the knowledge was not as brisk, but we know better and we just can't allow that to happen. So let me see if I can play a video for you. And I think for the young people, I want to play a video. So this is the medical school, and this happens to be one of our students. He's an MD PhD student, and he volunteered to have the vaccine trial taken. Basically, he and his mother volunteered to become first in line from a civic responsibility. So let me see if I can work this now. Well,
Try exiting out of full screen mode, Dr. Reece.
Okay, let's see. Okay. I'm going to enable it a little bit. Ooh. Ashley, you seem to be great.
It seems like it's not a video that's there, it's a photo. Do you have it pulled up somewhere else on your computer?
No, it would normally, I would just tap into it and it would.
You would have to pull it up somewhere else on the computer, because it looks like on the PowerPoint there, it's a photo, it's not a video.
I don't think so. I tried it before. Let's see something here now.
Can you click playback there?
Playback.
At the very top? And click play?
Where would play be, actually?
To the left of the screen at the very top.
Left.
The green triangle there that says play.
Ah, yes. I think you may be onto something, Ashley. Yeah, you are. All right.
And I think you should be able to click it now.
Volunteered for the phase 1 trial of Pfizer's coronavirus vaccine.
Can you try turning up the volume?
How do I do that?
You can turn it up on the video there if you hover your mouse over, or turn it up on your computer. Can you turn up the volume on your computer instead of on the video?
How's that? Can you hear it?
No, we can't hear it. when you share your screen at the bottom where it says share screen, can you try clicking on that in the Zoom option where you're sharing your screen?
Were you able to hear it at all?
We can hear it, but it's not very clear. So I think it's playing from your computer speaker. So if you go back into Zoom,
Okay, let's
the
see.
Zoom window.
So I'm going to, should I minimize this?
Yes.
Okay, so I'm going to minimize that. All right.
And if you go back into Zoom,
How do I do that?
is there an option at the top that shows anything, green button that says you're sharing your screen, anything like that?
Yes, it
Can you
does.
click on that?
That you're sharing your screen. Yes,
Can you click on that button?
I did.
What shows up when you click on it?
Well, there's I can see Zoom is there, Zoom and whiteboard and so on.
So is there a button there that's allowing you to also share your audio?
Maybe I'll click on that. It says share, and then this comes up. Let's try it one more time, see if play works. I'll try this again and see. Can you hear?
No, we can't hear. If you click at the bottom, if you click the button more, is there a button at the bottom of your screen that says more? When you go back into Zoom?
Well, I don't think it's going to work because it's not hearing it. Unfortunately.
If you go back into Zoom like you were before, I don't know if you see the option to stop sharing your screen. You can try that.
Okay, I do. I want to stop this video here. I'm going to go back. The option to share the screen. Okay.
And then have you stopped sharing it?
Yes. I'm back into Zoom.
Okay, at the bottom, do you see a button that says more?
No. I see share computer sound, screen sharing for video clip.
It's just 3 dots. It's just 3 dots.
Yeah, I've seen them before, but I certainly not.
Can you click share Zoom sound?
Share, yes, I see share computer sound. Is that the same thing?
Yes. Yes, that's it.
Yes. Try that now.
Yes.
So I'm going to go to playback. I'm going to start play. See if that's work.
Dr. Scott Balaban has volunteered for the phase 1 trial of the
How is
Pfizer
that?
coronavirus vaccine.
I'm very happy to be able to help out my colleagues and to do something that's also helping out the community at large.
But first, Dr. Balaban is tested again for COVID-19. His temperature is taken along with other vitals. With a clean bill of health, Dr. Balaban receives his injection, which could be the vaccine or a placebo.
This has been unprecedented. So I have to say that in my lifetime, I've never seen such commitment from different scientific backgrounds working together to create a vaccine.
Joining us exclusively now is one of the lead investigators in this trial, Dr. Kathleen Newsel, director of the Center for Vaccine Development and Global Health at University of Maryland School of Medicine. Thank you so much for being with us, Dr. Newsel. And first off, just how optimistic are you?
So we have a variety of different vaccines, both in development and, as you said, being tested right now. This particular vaccine, an mRNA vaccine, actually uses the genetic code. And then that genetic code is telling our own cells to make that protein, that surface protein that looks like the virus protein.
So the hope is that our bodies will be fooled into thinking it's seeing the SARS-CoV-2 virus, mount an antibody response, and yet the RNA itself will simply disappear.
The trial is being conducted with unprecedented speed and includes participants between the ages of 18 and 85.
Personally, both my parents are in the low end of the high-risk age group. My grandparents up in New England, that region has been hard hit, especially in spaces where people over 75 and 80 years old are living. So far, everybody's doing well, but I recognize on a personal level and on a community level just the urgency that there is to move these vaccines forward.
I am extremely proud to be a part of this study and also to be a member of this university community. I feel that their goal to improve the human condition is exemplified at all levels, particularly in a study like this, which will have sweeping impact against this pandemic.
In the communities hardest hit by COVID-19 and on campus here in Baltimore, School of Medicine researchers have begun a phase 3 clinical trial for the Moderna mRNA vaccine.
The primary aim is to determine whether the vaccine is effective in preventing COVID disease. And so this is really the key step to know whether a vaccine works.
The School of Medicine will enroll participants in Maryland's hardest hit communities, including Langley Park and Baltimore City, with large Hispanic and African American populations.
They're saying African American and Latinos are falling at a greater rate to this. So yeah, it's about helping everybody.
The Center for Vaccine Development is poised to start a new phase 3 clinical trial. The vaccine candidate was developed by Novavax, a Maryland-based company, and will be given to 400 participants in the coming weeks. Part of the nation's Warp Speed initiative, it's the CVD's third phase 3 trial aimed at COVID-19.
I'm very optimistic that these trials are going to have an impact not only on a local level, but also nationally and internationally. So I just couldn't be more proud of the effort that we're undertaking at the present time. So I'm going to try to get out of this and see if I can move to my next. So I'm going to summarize. I have two more slides. This is the second to last, and this is a summary. What I want to say is we need to know what's on the line. Healthcare and health security, they're the same thing. Health coverage ensures access to care, positive health outcomes, and also medical services, as well as reduced financial burden. As I said to you before, health insurance is critical for health care in America. That's on the line. The Affordable Care Act, as you saw, addressed 44 million uninsured and reduced it to about 20 million uninsured. Now we're back up to almost 30 million because the health insurance, the Affordable Care Act has been altered in some regard. That's on the line. COVID-19 jeopardizes not only health coverage for many people, but at the same time, if the ACA is repealed, would render the purchase, the individuals who have had COVID-19 ineligible for coverage because they would have a pre-existing condition. COVID-19 is a worldwide pandemic with no vaccine available, no antiviral available. It can be spread by droplets, but it can be controlled by simple public health measures. Efforts to develop COVID-19 vaccine are happening all over the country, but in Maryland, we're serving as a leading group. So end with we need to remember that this is a very unique season that we're in. We're in an election season. And so we have an opportunity to exercise a very fundamental right that we have, and that's the right to vote. And we have to remember what's on the line. So let me see if I can do one other. And this is a cartoon video on voting. And I may need Ashley to help me. Okay, let's
click on the photograph there.
Maybe it works. Yeah. Yeah, I think it's warming up. Yeah, I think you're right.
The election on November 3rd will come while America is in the middle of the COVID-19 pandemic.
Can you hear it?
While the thought of becoming sick is scary, Americans still want to exercise their right to choose their leaders. By following these scientifically proven safety measures that doctors and nurses follow in hospitals, we can vote safely. This is true no matter who you vote for. Voting by mail is the safest way to minimize contact with sick people and crowds at the polls. If you choose to do this, request your ballot and send it in well before the deadline. If you plan on voting in person, prepare 1 to 2 weeks before. Wherever possible, consider early voting when crowds may be smaller. Make sure to find a comfortable, well-fitting mask and buy a small bottle of alcohol-based hand rub. For extra safety, add eye protection or a face shield. Also, confirm your polling station and voting hours. On Election Day, if you feel sick, even a little sick, stay home. If you feel fine, plan to take the extra time, show up early, and be patient. Staying calm always makes things safer. Wear your mask and, if available, eye protection. Wash your hands frequently, especially after you arrive, if you touch any objects, and after you leave. Maintain about a 6-foot distance from other people as much as possible, and remember that being outside is safer than being inside. While waiting, consider letting elderly and disabled voters go first. Your goal is to be safe and to make sure that everyone has the opportunity to vote. You can vote and be safe. Remember, wear your mask, bring a bottle of alcohol hand rub, consider wearing goggles or a face shield for extra protection, maintain a 6-foot distance, and lastly, be patient and plan ahead.
So this is a video that one of my faculty put together that we have circulated because we think it's It follows the CDC guidelines. It's very straightforward. It really supports and encourages voting for everyone as a civic duty. And we have an opportunity to let our voices be heard. So I hope that I've shared with you the state of affair of health in America, I should say health care in America, that's very much predicated upon health insurance and the need for every one of us, to the extent possible, to secure health insurance if we can. And the Affordable Care Act is certainly one measure by which we have made significant advances, but at the same time is now on the line. So with that, I want to thank you for inviting me. Thank you for listening to me. And I'm happy to answer any questions that you may have at this time.
Thank you so much, Dr. Reece. We do have a few questions. Our first says, it seems that everyone is talking about healthcare in a way that it will be resolved if everyone voted. But the problem is that racism is baked into our system here in the United States. If you are wealthy, you can have what you want, but if you are Native American or Black or brown, it seems out of reach. Do you think racism is the issue and the government that exists now will not come together to change? And it seems to me also that COVID-19 started here in the United States. I think history always repeats itself.
Well, I guess we have, Ashley, you can help me to open up my screen so I can see more people.
If you exit out of screen sharing, can you see at the top an option that allows you to exit out of screen sharing?
Let's see. I see new share, pause, annotate, remote, stop video. No, I don't need that.
If you click stop.
Stop video?
No, not stop video.
I see more, the three dots. Would that help?
Try clicking more.
Yeah, it has disable, hide, share, optimize. No, I don't think I need that.
Do you see an option there that says chat?
I'm sure that one is here. Stop sharing, security.
Stop sharing, that's what it is.
Let's see.
If you click on the option that says stop sharing, you should be able to exit out.
What if I escape wouldn't do it, right?
The button that said stop sharing?
I can't find it again. See, stop video, I saw that one. And security.
It's a red button.
Oh yeah, I do see it now. Okay, here we go. Perfect.
Okay, and if you look at the bottom of your screen, there should be a button that says chat, and you should be able to see the questions there.
I'm less interested in the question seeing many people. Is there a gallery shot? Is there a gallery? Where would gallery be? Where would I find the gallery box, Ashley? Look.
The top right-hand corner, I believe.
Let's see, view. Yeah, here's gallery. Perfect. That's what I'm looking for. Okay. Well, it seems to me there's always, one has some choices. One can do nothing, and one can predict the outcome. And one can do something, which is vote, and you may have a better outcome. So it seems to me the option is very simple. If you do nothing, you're going to be where you are, or worse. If you do something, which is vote, you may have a bit better outcome. So it's always better to make an effort, regardless. I think it's never appropriate to take the defeatist attitude, to say nothing ever can happen, because things do happen. I think, as Dr. King has said, the justice, the arc of justice is very, very long. So we have to always make an effort. We can never assume that nothing will happen, because things do happen. They happen very slowly, and sometimes they don't happen the way we want. But at the same time, we have to be very positive, proactive, and absolutely vote. To me, not voting is never an option. Not voting is sort of like illness. You know, someone said, you know, I'm not going to do preventive measures. I'm going to die anyway. I mean, that's not an option. You should at least try to eat healthy and to do all the healthy things. It's likely to result in good outcomes. That doesn't mean it guarantees you. It doesn't guarantee you a great outcome, but it really improves your chances. So voting doesn't guarantee the outcome that you deserve or you desire, but it really improves the likelihood that will occur. It's like anything else. We walk out the street sometimes, and we may, unfortunately, have an accident. Does that mean we stop walking out in the street? We walk carefully, but we still walk. So I think doing nothing is never an option.
Our next question is asking, what is your prognosis for the next 6 months as far as the virus spiking across the US again, and should we take the flu shot?
Good question. We should take the flu shot. I had mine last week, number one. Again, that's doing something. That's doing the best you can. Number two is a very good chance that there will be another resurgence. If you look at the states, including your state, for example, there's a rise in almost every state, and it's almost like a third hump. You know, the first rise sort of didn't go all the way down, and it's a hump again, and now it hasn't gone down and start again. So clearly, I believe that, and many hospitals are preparing. In fact, at Maryland, we're preparing so much that we have a parking lot, and we have created a mobile ICU on the parking lot in preparation for more ICU patients. So the answer is yes. In the first wave, we prepared, both Johns Hopkins and Maryland was asked by the governor to create a field hospital. And we turned the convention center into a field hospital. Now, thank God at the time, we didn't have the amount of patients that we anticipated. So it wasn't that full. But this time we've decided to really create ICUs at the parking lot. And it's already built, it's waiting. And we're gonna be using our own faculty to work overtime to really staff that. So the answer is yes. What was the first part of the question, Ashley?
The first part of the question was asking, what is your prognosis for the next 6 months in terms of the virus spiking across the US again?
Yes, my prognosis is definitely will spike. It is spiking already, and so we need to be prepared, and we should take the flu vaccine for sure.
Our next question says, what impact will repeal of the ACA have on hospital emergency rooms?
You know, it will have a really bad effect. I told you I was going to give you a story during my talk. I'm going to give it to you now. There's probably almost every physician in America, physicians who are in this audience, will have a story to tell you about seeing patients who have not had insurance that they could have made a difference in, but they couldn't because they didn't have insurance. Emergency rooms will be filled again because that's where patients go when they have no insurance. And unfortunately, they go when they're... Here's my story. It's just one example, and it's dramatic. So, as Dr. Hoyler described, my field is obstetrics and gynecology, but my subspecialty area is maternal fetal medicine. So at the time, I was practicing gynecology. I don't practice gynecology anymore. And a patient came in and was referred by orthopedics. It's unusual for orthopedics is referring to gynecology. But the patient went to orthopedics because her legs were swollen. And the orthopedics checked her legs and it seemed fine. But I think maybe by accident, the orthopedist maybe took the abdomen. Orthopedics typically don't examine women's abdomen, and felt that it was hard, and asked her, what is this? She said, it's been there for a long time. So he sent her to gynecology. When we saw her, it was clear that this lady had a huge tumor in her abdomen. I mean, you didn't have to be too smart or too experienced. You know, you could feel it's like big watermelon. It felt like the whole abdomen. And it turns out that this watermelon tumor was compressing on her vessels and preventing her leg blood flow. So that's why her legs were swollen. And we asked her, how long has this been there? She thought at least a year, maybe more, maybe a couple of years. But why didn't you check it out before? Well, I had no insurance. So she waited until she couldn't walk or was having difficulty walking. Then she went to the emergency room. Orthopedics saw her for the gynecology. This is the first patient I've ever seen who we're going to take her to the operating room the next day or a couple of days later. She was signing the consent form for the OR, and she was signing a will, same time. It was the saddest thing I've ever seen. I've never seen one like that before, because she's smart enough to know that the chances are she's not going to wake up. We took her to the operating room and made a huge incision because it's like a watermelon. I mean, a big watermelon. I don't mean a regular watermelon. And the whole thing was encased. I mean, literally could not be moved. It was just encased. We just took a piece of tissue out, sent it to the lab and waited. It's called a STAT section, emergency examination. Just tell me what it is. It seems like it's obvious to us that it's malignant, but you give us the word. Within half an hour, we waited, came back, metastatic advanced cancer. We just closed her back up, woke her up, told her that we confirmed it. She died before she left the hospital. This is a lady, and there are many other stories where patients without insurance don't get, elective care or medical care, but they wait until it's too late. They go to the emergency room, that lady. So the answer is yes. It's a long answer to there's no question. And I guarantee you every physician have at least one story like that one. Most likely many stories like that.
Our next question says, there has been repeated assertions by the current administration that the ACA would be replaced by a new and involved health insurance program. Do you know if such a program exists that is ready to go if and when the ACA is repealed?
The answer is no, I don't know. I've never heard of it. That's my answer.
Well, next we have, there has been some concerns regarding CO2 and mask wearing. What are your thoughts?
It's theoretical. It really, mask wearing is if you go to Asia, even before COVID-19, go to Asia, Japan, China, people wear masks routinely, usually for smog and for protecting themselves. So if mask wearing created such imbalance in your oxygen CO2 ratio, you'd have a lot of injured, dead people across the world because Asia is so commonly used. If you wear the N95, that's the really tight, secure one that doctors have to wear. You may find that your oxygen is sometimes a little. You need to take it off and refresh yourself sometimes. We have a daughter, or my middle daughter is an endodontist, so they have to work through the COVID-19. They're essential workers. So she has on an N95 all day. And sometimes she said she's very tired in the day because it is so tight, because try to protect, it's not a regular mask. The regular mask that you wear has enough play that you don't have any issue. But for surgical purposes, they have it quite tight. And if you're doing surgery all day, then you may find that you need to take it off sometime between cases, breathe a little bit, get yourself reacclimatized. But the answer is there's no issue of there's no significant issue having CO2 build up or that. That is not an issue. The bottom line is that wearing masks is such a fundamental part of staying healthy that overrides any other thing right now for the population.
Wonderful. We have one more question that asks, what can individuals in the healthcare and medical care community do to combat the lack of healthcare providing that different communities face?
I didn't understand, Ashley, I didn't understand the end of that question.
It's asking, what can individuals that work in healthcare and medical care do to help provide medical care despite the fact that people don't have insurance and things like that?
Sure. So it is physicians or nurses, at least physicians take an oath to provide medical care and to do all that's good for patients. And so it will be, you should not be seeing physicians turning away patients, physically turning away patients. So that's one of the reasons why emergency rooms are so full sometimes, because the patients are coming in and they have to be seen. If someone goes to get seen, a doctor's not going to turn them away. So there is maybe a culture for physicians to provide care for patients. There are a number of pro bono, no free care that is given all the time by physicians. However, as I said, I mentioned it when I spoke at the Senate, by saying that because that's not the kind of care patients want. They need to have preventive care. They need to have acute care. They need to have chronic care. They need to have ongoing care. They don't need to have care just by a doctor having, let's say, a free clinic and seeing a bunch of patients today. So the answer is yes. There is free clinics. There is free service given, but that is not enough. It is sufficient. It is just. It's all. If there's nothing else, it does help. But I'm saying that we do need to have better health coverage, health insurance coverage, so you can have better health care. It is just so fundamental. Health insurance in this country. As I said, other countries, in Sweden or Switzerland, for example, 3 things are important, fundamental: health, education, transportation. Those 3 things are free. Free meaning the country's taxed, but those 3 things are provided. France, Italy, those things are provided free. We have a different system in this country. We believe in purchase services, but you got to be able to afford to purchase. And we also have insurance linked to employment. So if you're not employed, or you're underemployed, or you may not have the health insurance to have the health care. And they're not having the health insurance and the health care leads to higher morbidity and mortality. So physicians should help, and most do help, but that is not enough. Going on a mission trip are great, and we want to go on a mission trip and help, but you can't just depend on mission trip alone. You got to have a much more of a ongoing support service.
Of course. We have a question asking, in reference to what you mentioned earlier, you said that you would explain why there was an increase up to 28,000 recently in people who are not covered under the Affordable Care Act.
Yes, I implied, I somewhat speaking, and that is because there is an erosion in the ACA right now, then a certain number of folks have fallen out of that coverage model. So, for example, because there's no mandate anymore that requiring people to have insurance, there's a certain number of people who just don't do it. There's quote unquote go bare. They go without it because you don't have to pay for it, so that they will not do it. So that's a certain number. If that states do not have Medicaid expansion, for example, in my state, we had Medicaid expansion. So there about 15% of our patients were uninsured before the ACA. After ACA, about 4% were uninsured. So right there. Now, we still have the ACA. We still have the Medicaid expansion. So our numbers are still low. But in another state, for example, that chose to either not to expand Medicaid or chose to add work to it, you'll find that the number of persons will be fewer, fewer covered. So there is sort of a nibbling around. There's a little nibbling, a little erosion here. As a consequence, there are fewer patients on the Obamacare or ACA coverage. That's why the numbers have risen up from about 20 when he left office to about 28 now, 28, 30 now. So it kind of went in the wrong direction. Before the ACA was launched, it was 44 million who were uninsured. And after the ACA was launched, it came down to roughly 20. And we in the medical profession was hoping that with some more tweakings, it would come down to 10. And maybe at some point within my lifetime, everybody would be covered. It'd be great. It really would improve health outcomes.
Our next question says, we hear the term socialism a lot when it comes to healthcare. What are your thoughts considering we have SSI and Medicaid?
Oh, I think it's an ill-advised term. It's not socialism. If it is socialism, then Medicare is socialism, and if that or Medicaid is. Nobody would get rid of Medicare. We're all going to get old. Some of us are old, so we gladly want to have Medicare, and people who are disabled or people who are below a certain poverty level gladly want to have Medicaid. So it's not. So these are just terms, throwaway terms. As I said, this is just fundamental. This is not a debate. It shouldn't be a political issue. It's just a straight healthcare. Give an example. I went to Canada maybe 5, 6, 7 years ago. I forgot now. I was speaking at McGill University, and when you're a guest at the university, they take you out to dinner the night before. They walk you around. They show you around, and you meet with other people. So I was out even before, and these folks who invited me, I was their guest. We entered into a very robust discussion. They couldn't understand why America was having a debate over health. They said, this is something that we don't control. We don't, everybody's gonna get sick at some time, we're gonna get old at some point. It's not like it's only some people and not other. It's so fundamental. I found myself for a while I was explaining why, but I caught myself by saying, I don't really want to be defending. I want to just explain some of the reasons But we ended up in America, basically ended up debating it. It's not a debatable issue. So it's not a socialism. It just says a social, it's a fundamental requirement for life, healthcare. You cannot live without healthcare. Those who don't, and it's data, it's not my feeling, those who do not have healthcare have a higher death rate and a higher illness rate and a shorter life. It is not debatable. Those are the facts. So if you want to promote those three things, then you promote no healthcare. And the converse is true. You want to promote longevity, high quality of life, low morbidity, low mortality, and then you promote healthcare. So it's just straightforward as far as I'm concerned.
Our last question of the evening is, what is the attitude of doctors in the American Medical Association to adding a public option to ACA?
I don't know what the American Medical Association position is, but I would say that doctors that I interact with, physician groups, would have no problems with it. And the reason why is that the public option is basically just is another option. It's not a requirement. It's an option. So it's sort of like a multiple choice. Yeah, you can check off different things. Some people would like it. Some people won't. Some people want private insurance. To be honest, one of the nice things about the American healthcare framework is the variety. Americans like to be individualistic people. Some want something, another one want another thing, another thing. We don't like, our culture is not very, it's not very supportive of kind of a one size fits all. Europe has had that culture and it works well. So here in America, you can choose private insurance. And you can choose a variety of private insurance. You can shop. You have public insurance, and the public option is really just kind of for people may want to choose a public option. So we wouldn't have an objection to a public option. We're so happy when people are insured. We don't really care what option they choose. We just want them to be insured. It could be public, it could be private, it could be anything. Once they can see a doctor, again, keep in mind the principle. Our profession is maintaining people's health. Health maintenance is our goal. And health maintenance is best achieved through having insurance. So it doesn't matter to us what insurance people have, provided they have insurance so they can be seen and stay well. As simple as that.
Absolutely. We do have a few questions asking about if you could make your slides available so that we can see them later. I don't know if you could possibly email them to Pastor.
Absolutely.
Okay. Well, that's it. Thank you so much for speaking to us this evening. I know that we all learned a lot, and we're all much more informed now about the healthcare system in the United States and things we can do to influence it. And I'm going to go ahead and hand over to Pastor so that he can close up for us.
Ashley, thank you very much. Thank you very much for your technical skills, your moderator skills, and Dr. Holland is very lucky to have you. So thank you.
Thank you.
Absolutely, absolutely, Dr. Reece. Ashley is a gem for us, and I'm happy that she was of help to you. Some of us have to still learn the technology to be efficient, and we're thankful that the young minds are able to do that.
Absolutely.
Want to appreciate your presence again, and some folks have been texting in, calling, say this is a fantastic lecture. We're very pleased to know that your expertise is being provided for our larger problem here of developing a vaccine in your university. And I had not known that before. I hadn't caught that on the news that your university was one spot for that development taking place. So we're looking forward to some good things to come out of that. People are still wondering because of the politics involved in healthcare and therefore the vaccine, how would one trust a vaccine if it comes on the market touted by current administration and be here, it's coming soon, to be ready soon. And so different positions obtain on that as to what soon means. And so we have some unanswered questions about the effect of politics on our medical care. Why is it we can't be free? Why is it we can't provide this type of security and safety for our populace? And why is it that other countries are able to do so? Seems to me that that type of freeing of ourselves is stuck in the realm of politics, and those people who have the wherewithal to make the money that will keep us in a bind, so to speak. And maybe as you visit the Senate going forward, there can be some recommendations from the AMA to give us some hope for the future, Dr. Reece. I still think that we should have different people who are involved in trying to find the best way to take care of people. And I don't know what has been done on that front before and whether it has fallen on deaf ears. I don't know if you have a moment to just mention anything that might have happened in time past as we think about senators and politics and governance with respect to why is it that we're still not having free healthcare in America?
Well, I think that is a ongoing dialogue that I believe is also in current discussion as we speak.
Okay.
Is on the ballot.
It's on the ballot.
It's on the ballot.
Okay.
And I think there's no question, like I said before, that healthcare is, to be honest, healthcare has been on the ballot now for maybe at least 3 terms or 3 election cycles, and is certainly on this one again. You know, we've come some distance with regard to making inroads. Here we have another chance again, and I'm optimistic that each time we're going to chip away, and we have to remain positive, optimistic, and we have to vote.
Yes,
I think that is absolutely, we have to vote because we have a civic duty to vote, and health care could not be more fundamental, and that's on the ballot.
Yeah. Thank you for that. Just want to appreciate your presence again. Thank you so much for this in-depth lecture. We owe you a lot. We know it takes time and presence to, for you to lend yourself to the Lehigh SDA Church. We're thankful for all those who have joined us. We have family here, and I know your in-laws and your sister, they're all here, and friends like Dr. Patrick Rutherford, I noticed earlier on, I see him still around.
Yes,
and we have, Dr. Valerie, also Dr. Clark. We have Dillard. We have a lot of physicians around and who are interested in this topic. And my family also here. I see Linville. This is important to us. Throughout this month, we are doing this to have our people be more educated towards the same words that you use, the importance of voting. And it's a civic responsibility. I'm thankful also that on next week, we will have another presentation, our final presentation for the month with Dr. Trevor Gardner II, and he'll be looking at the other problem we have with respect to policing and the lives of our Black men and women in our country. He is a criminal justice professor and an attorney, and he will lend his energies from Washington University to be with us next week. We have had some great presentations for the month, and we hope that when it all comes to the end next week and we hit November 3rd, it will make a difference if we really get it. And I want to make a last point, that whatever we do now may be incremental, but it still is important, because we have had incremental movement over the last, I guess, 100 years, and then over the last 60 years, and then over the last 50 years. And every day there's a potential for things to be better. We have been slipping backwards. That's the anomaly, instead of moving forward with those increments. So I think this time the increment is a larger step that we hope for. And I trust that people do not lose their health care because of our inability to face the issues or our reticence about voting in our community as Christ followers. So thank you for adding to this conversation.
So Dr. Hoyle, I'd like to make one other comment, if I may.
Yes.
I just want to recognize, I see a few faces. My brother-in-law over there, Linval Henry.
Linval, yes.
Yeah. It's him. I haven't seen my sister Lorna, but I figured she must be in the background.
Yes.
I saw another of my sister, Hyacinth. I saw her face.
Yes. Yeah.
I haven't seen her again. And all other relatives and friends, Dr. Rutherford over there, I want to say hello to.
Thank you. Yes. We appreciate the families coming together. Brandon and Carden are here again tonight.
Oh.
And we appreciate that. And
Norma left. Hello to them too.
Yes. And Norma was here as well. Thank you, folks. I'm going to pray us out. Again, Ashley, great job. Fantastic job. Appreciate you. Appreciate the anchoring. We're thankful. I think Genevieve needs to come back and give us the prizes or the winners. Is she around?
I am.
Okay.
Okay. So
winners.
the verdict is in. It's Sister Nadine and Susan who fought really hard.
Oh.
And so I couldn't decide either which one.
Oh boy.
Yeah, one. So our two winners, Nadine and Susan. And thanks, Sister Ruddock, for your voiced answers, even though they don't count because they have to be written down. So I already have those two email addresses. I will send the prizes this week. Next week, it will be a bigger prize. So come back, and it will not be on Pastor's sermon. It will definitely be on the scripture reading for the sermon.
Okay. All right. Can people just go in their virtual section on the more and just put a hand clap or a thumbs up for Dr. Reece? I'd appreciate that if you can find that where you are. And we'll be, I see a couple of them up, if you can do that. Oh, Thelma is here. Good to see you. All right. Just wave. All right. Appreciate it. And Karen is waving. Those of you who can touch, yeah. And Dr. Michael Allen is also here.
I'm just seeing him there.
Yeah,
Michael.
Yeah, he led us off on the first weekend of October. Fantastic. And so we appreciate
Thank you. It's great.
Yeah, thanks. Good. Thanks for checking back in. Dr. Valerie is also here.
Yes.
Let's see. And I think Dr. Vonda just left, that she is the sister to Dr. Douglas. They were here last week as well. So we appreciate the attention to this program this month, and we trust that it will be for the good, Dr. Reece, as we go to the polls on November 3 for healthcare.
Yes.
All right. Let us pray. Wonderful, good to see you. Let's pray. Heavenly Father, we know and we have read and we have certainly repeated the scripture that it is your desire that we prosper in health, even as our souls prosper. We have come to the point where we have to bring these two things together, Lord, and we're trying to do so. And we are here as Christ followers, figuring out the importance of our civic responsibility along this pathway that is called voting. And I pray, Lord, that you'll keep us consistent in our activity beyond the vote, so that we can keep a tab on our health, not only for ourselves, but for our community. The community of Lehigh and Fort Myers and Cape Coral and our surrounding areas of Naples, LaBelle, and Sarasota, or the areas of Port Charlotte, where we serve our people. We ask, Lord, that we will be an effect on the community as we come to have our virtual health fair in another few days on the first Sunday of November here. We pray that that will be a part of the renewed impact that we will have as we keep our people in our community as aspects of care that we will provide or be channels for as a church community. So give us wisdom, give us understanding, and give us the will to do. In the name of Jesus, I pray. Amen.
Amen.
Amen.